Hey, and welcome to the Gait Geeks podcast. I'm Iva Warlup in Dillon, Colorado. I have with me my partner, Scott Greenberg in Gainesville, Florida. Today, we're going to be talking all about orthotics and orthotic therapy.
So I think oftentimes we get asked the question like, what is a foot orthotic, right? And how does it differ from a footbed? Sometimes I call it a sock liner, but footbed is probably a more technical term. In my opinion, I think the easiest way I would say it is an orthotic is a footbed, but not all footbeds are orthotics. Would you agree with that?
I would. We define it just a little bit different. We
Mm-hmm.
define it as a footbed creates a level surface for the foot, whereas an orthotic changes the mechanical function of the foot. Orthotics are always prescription devices and custom made, whereas a footbed can be something that's off the shelf or something like that. Not to say that that's not appropriate in a lot of circumstances. We always try to steer people towards the more cost-effective alternative in our office, and there are quite a few out there. I know you've got a company you work with. We work with Cadence Insoles quite a bit. They're totally modifiable if you've got a little mini lab in your office. And in addition to this podcast, we'll talk at the end just a little bit about an upcoming seminar that we have where you can learn about all that stuff. But yeah, we always like to say that orthotics change the mechanical function of the foot or give people a range of motion that they are not able to attain yet. In other words, makes up for what they don't have. They can't get the first to the ground, then you bring the ground up to the first, and then training them, hopefully with exercises, therapy, whatever it is that you do, to get that first down to the ground, progressively pulling correction out of that orthotic device. Same deal with a footbed, except that it's not custom. It's made to fit 80% of the population. Unfortunately, the 20% that's not working for are usually ones that end up in your office.
So a question that I oftentimes think of when this kind of debate comes back and forth between the differences between the two is, so like the term prefabricated orthotic, how would you classify that in this continuum?
Prefab orthotics are footbeds.
Correct. All right.
And
good.
that's how we call them. And working with the ski industry a great deal here, we run into this all the time. We've got a local company, actually several local companies that build footbeds for people, and a lot of times they're totally fine and they do a fantastic job. They create that level surface. They use a little laser system on the knees and all this stuff, and it's all fine and dandy until somebody has internal torsion and they immediately post them, and all of a sudden they've got raging pain on the outside of their foot because you're just pushing them further. So what do? They blow out the side of the boot, which just allows them to slide further, west, and just creates the problem.
Yep. Agree. Perfect. Yeah. And so you kind of started talking a little bit about that, but in terms of why orthotics prescribed. So, I usually see it as two different functions and maybe even sometimes three, but I'll start with the basic two, right? To change the way in which the foot interacts with the ground, right? To change the kinematics of the lower extremity, orthotics can dictate what happens more proximally based on how you manipulate it, how you post it, how you support it, those type of things. So that's more of a structural kind of repositioning. And then there's also the accommodating more dispersion of forces side of things. So those are the main two reasons why I see orthotics prescribed. The last one I'll say is a little bit funky, and I'm curious as to your thoughts on this. But in my world, dealing with certain shoe companies and certain licensing deals we have at the university, all of my athletes have to be in, let's say, a Nike. For hypothetical stances, we'll say Nike, but it is Nike. And we all know that not all feet fit nicely in Nike shoes. So I do sometimes say that an orthotic that is custom derived, molded from the person's foot, which is more, let's say, cushion driven, can create a custom, I like to call it a custom footbed for that particular individual, where that Nike shoe may feel more comfortable, more natural to them than it would otherwise. Where do you kind of line up with why are they prescribed and that last aspect I brought?
So what we do is, and I'm sure you do the same thing in your office, we try to see what the functional ranges of motion are for different motions and what they're going to be using that particular type of footwear for, whether it's a sport or whatever. And if they lack a certain range of motion and they're not willing to work at it, or they're not ready yet, like they have a first ray that won't descend, which is a super common problem, and they've got a little bit of a hallux limitus, they can't toe off appropriately. With folks like that, we will a lot of times bring, well, it depends. If they have the range of motion available, but they're not using it, then we'll put in like a first ray cutout. So we'll allow that first to drop down. If they don't have the range of motion, then we have to bring the ground up.
Mm-hmm.
But I'm not a huge fan of forefoot posting, only in certain circumstances. In that particular case, we would rear foot post, and we can get into that a little bit later. But again, we prescribe to give people a range of motion or a functional range that they do not have. That's the biggest thing, or they're not willing to put the work in to get. A lot of people are like, look, you made orthotics for me 3 years ago. I wore them. They stopped working 6 months ago. I need a new prescription. I don't want to do exercises, and I'm sure you get that too. And we're like, all right, fine. We'll just build you a new device, and you can come back and see us in a couple of years again. And the problem won't get better, but as long as you understand that, we're fine. And we've got a waiver that everybody signs as far as that kind of stuff. And that'll get into something we'll talk about at the end, more like orthotic therapy. But that's why we'll do it. We don't prescribe orthotics or footbeds for everybody. Sometimes it's a temporary thing. Sometimes it's unilateral, depending upon that. Or we have a relatively neutral footbed, or because we have a small lab in the office, we do a lot of mods right in the office. I'm able to add posts, make changes, heat mold. We've got all sorts of EVA and grinders and stuff, so we can, put a scaphoid pad or something like that in for somebody, no problem, especially if it's you're dealing with people that are climbers, when we've had to build some funky things for climbing shoes. We have people that are professional figure skaters or hockey players, and you can't fit an orthotic in a hockey skate. So we have to, modify the inside, which is, I guess it's sort of like an orthotic, but it's not really an orthotic to that. But again, orthotics are prescription devices. They are custom made to that individual. And that's, that's our semantics in the office.
So another thing I'll just like to bring up too, and I often speak and talk on this topic, is in my world, I usually say I have two goals to achieve. Number one is to keep my athletes on the field performing at the high level that they can safely. And then secondly is those that are injured for whatever reason, to get them back on the field as quickly and as safely as I possibly can, right? There's a lot of money riding on college athletics, as we all know, and a lot of pressures. And what I oftentimes say is that if I can temporarily put an orthotic into somebody's shoe and offload a damaged, injured piece of tissue, it may not be necessarily ideally how I want them to, per se, walk. But if I can offload that tissue to allow that injured tissue to be less painful, to allow them to perform at a certain level, I'm going to try to do that. And no, like you said, it goes back to the orthotic therapy side of things, whereas that may not be the long-term answer, but what it is a short-term means to an end in which I can allow my athlete to do the task, the activity, the sport that they need to do, while, you're robbing Peter to pay Paul, right? So stresses don't necessarily disappear in thin air. They're absorbed by other tissues. And depending on how you make that interface will dictate what tissues absorb most of the load. So, I think that's where a little bit of the art comes in to some of this. Sure, there's science and we have certain type of foot alignments and certain type of pathologies that we want to use common ways to deal with them. However, in other cases, I think we need to try things, see how they respond, and if they don't work, try something else, right? So it's not always a one size fits all.
Oh, absolutely. And we do that a lot with people. Right now, the Leadville 100 is coming up here. We get people that come in from out of town, anywhere from 4 weeks to a week prior to prep for the race and train at altitude, because the race starts at 10,000 feet in Leadville, and it does 10,000 feet of vertical. And it's 100 miles long. And we'll have people that come in with a raging Achilles tendinopathy that they want to finish the race. So you help them with the understanding that, like, look, this is not the cure. This is going to get you through, and this is going to help you. But we really need to address, X problem. And some people will address it, and some won't. But I agree. We do a lot. It's about return to play. It's about returning mechanics. I always explain to my patients that it's like, all right, we're doing this, and it's going to make your let's just say it's their foot. It's going to make your foot feel better, but you're probably going to notice some pain north of your foot, in your knee or possibly your hip or even the contralateral shoulder, because this is what we did. And if that's the case, during your training, we need to make this change for you. And some people are like, oh, well, as long as you make the, fill in the blank pain go away, I can handle it. Yeah. But yeah, we've done that. Or even like with manipulation, and I think you use manipulation in your practice too. If you have somebody that, let's say, has a hypomobile upper cervical spine and a hypermobile lower cervical spine, to get that upper cervical spine to move, we will induce pathomechanics in the lower cervical spine to make it hypomobile, to force the upper cervical spine to work better. And that was a concept, Dr. Carrick, when I did my training, brought to me mind. And first I'm like, oh my God, you're going to like do something that's going to like make something not move right. As a chiropractor, that was like a really big no-no, but it really made a lot of sense after he said it. I said, well, look, you're not going to leave it there. You're going to induce these pathomechanics. They're going to go for a week or two. Then you're going to take them back out and, you're normalizing the stresses on the tissue. So it made total sense when you think about it like that. In orthotics, we're just using an external means to do that. And, as you can do lots of cool things with orthotics as far as fixing not just foot and lower extremity stuff, but back stuff, neck stuff, shoulder stuff, all those things. Yeah.
Agreed. And again, in terms of the types of orthotics, this is where, wow, you can really be very creative, very unique. And that's why, oftentimes I'll tell my patients, like, we can take the same mold of your foot, send it to, 10 different people and have 10 different orthotics come back as to what's right and what's appropriate. And, certain people are very comfortable dealing with certain materials. Certain people work with labs that have certain materials only. Other people, like the way that a certain material interfaces with glue so that they can make their own modifications. People like hard versus maybe, a rigid material versus a semi-rigid material, depending on the sport, the activity. So all of that kind of comes into play. 3/4 length versus full length. We can have our discussions as to what's appropriate there. In my hands, I'd much rather go with a full length orthotic if I could, depending on the foot type and the shoe I'm putting it in. Certain times, a cleat or a track spike, I may go 3/4 length just because the toe box is so narrow and the spike shape is such that it doesn't really allow for it. But again, from my eyes and my hands, types of orthotics really, really vary based on the sport, the body weight, the materials you're comfortable with, etc. Do you have anything that you like to think about with regards to that?
I would agree, with that. You've got accommodative, which is basically softer, more forgiving. In our office, that's an EVA product, ethyl vinyl acetate. You would use 75 durometer EVA for that. Totally moldable, totally great. Has probably a usable life of maybe 3 years. And then they really get broken down a lot, depending upon how
the durometer
heavy,
too. If you use a lower, like a 40 durometer or a 50 durometer material, forget it. You're going to bottom that out pretty quick.
Well, it's like wearing a Hoka shoe, like they're really, really comfortable for the first 350 miles. And then after that, your pathology is worn into them. So the lab that we use for EVA only uses 75 durometer.
Gotcha.
So that's our softer, and I can grind it out. I can make the arch less or more or whatever. And then we use an acrylic and then carbon. So we'll call them accommodative and non-accommodative as far as that goes. Some people will not tolerate. We have a tendency, and I don't know in your office if you do, we're very aggressive with therapy and orthotics and everything else, just as far as we're going to put in as much correction as they're going to tolerate. And then I can always temper that off and then start pulling that correction out as they start to improve. That's just in our book, that's worked the best for, the last 30 something years. So we're not going to change that. But yeah, accommodative, non-accommodative. I think that's the broad category. And then within orthotics, there's lots of things. So let's say you have somebody that's got a ton of calcaneal eversion, and they really pronate through their midfoot. So then you might use a super duper deep heel cup with a medial flange, over the arch, something called a modified UCB. For building that. And we'll use that in extreme cases, usually adolescents or children that have extreme rear foot valgus and midfoot arch collapse, to get them back, just so you can get, you're bringing the origin insertion of the ligaments together over time so that they remodel and become shortened, and then they can
Would you ever
have
medial skive
normal
them?
anatomy.
Would you ever put a skive on them, or would you? And you know, a skive is basically almost like a slant built into the orthotic for a term.
Yeah. So sometimes we'll put them in varus.
Uh-huh.
As far as that goes, the whole orthotic. Sometimes it's just we're pretty aggressive on the arch, so when we cast, we put a lot of stress right at the sustentaculum tali. My education and makes my experience is if you can control the rear foot and the sus, you can pretty much control what goes on with the rest of the foot. I don't like the forefoot post because as soon as you start messing with the MTP joints, you mess with their ability for them to start to extend because you move the axis of the joint dorsally and posteriorly, which inhibits extension of the joint. We see that with forefoot varus posts or Morton's toe extensions with the first MTP all the time.
Mm-hmm.
And if you do that, you just have to be aware that like as soon as you pick that up, you're asking for some trouble in that joint, in that area there. So yeah.
So what materials did you say you favored? Did you say it was carbon fiber for the more
We
rigid
use
ones?
so for super rigid carbon fiber.
Uh-huh.
For a lot of rigid orthotics, we use it's a thermomoldable plastic. That's
Uh-huh.
what the lab uses.
Which, do you know which one?
I don't know which plastic it is. It's beefy.
Okay.
Like I can put a 300-pound patient on it and it ain't moving.
See, the way
As far
ours
as that
work
goes.
is we go with a plastazote, which is a
Uh-huh.
thermoplast as
Yep.
well. But depending on the size of the athlete, we can dictate how thick we want to make it. So, like a piece of plastazote that is 1/8 of an inch thick is going to handle a 300-pound athlete a lot different than it's going to handle a 150
Right.
pound versus a 100-pound athlete. So that's how I kind of manipulate how flexible or how rigid I want my device to be based on the
Mm-hmm.
thickness of that material. One of
We
the
do
ways.
that and we just grind the arch out. So that's what we'll do.
Same idea.
It's the same thing. Basically, we're taking that plastazote and we're just making that layer thinner. And we're either doing it or we're having the lab that we utilize do that. A
Mhm.
lot of times they'll use EVA with the idea that the person's not going to be in the device forever. And I'm hoping within 3 years that I can get them out of a device.
Mhm.
And that's much more accommodative. It's much better or easier for people to tolerate. Although I
Mhm.
have to say, once people get used to the hard plastic and the rigid, they really like it. And if you give them anything softer, they're like, "This ain't working for me."
It's
I
very
need
funny
that
you say
support.
that.
Yeah,
It's
yeah,
very funny because when I used to make them in the clinic, start to finish, start with a nice long, rectangle of EVA, and heat it up and grind it and the whole kit and caboodle, start to finish. They used to be very light and soft, and patients typically liked them, but they took up a lot of space in the shoe, I found, right?
yeah.
And then when you go to more of a thermoplast, they definitely are more they're lighter
Hmm.
oftentimes. They fit in the shoes a lot easier. It's definitely an issue, but I agree with you 100%. Whereas, you know, patients really like the EVA. However, those that really like the semi-rigid thermoplastic ones, if you can convert the EVA to that, they much prefer that. It's just that first selling point of, hey, this harder type of material I think you're going to like in the long term is a little bit tougher sometimes.
Well, it's definitely tougher for break-in
Mm-hmm.
because the orthotic's not. It's like when you get a new pair of hiking boots; they're
Mm-hmm.
breaking you in. You're not really breaking them in.
Right.
As far as that, we had one patient that I can remember, and I've been doing this for like over 30 years, who kept breaking orthotics. He even broke the carbon ones. That's how hard this guy was on orthotics. It was incredible. Like he brought back the first carbon pair we built and broken. I called the lab. They're like, "You got to be kidding! He broke the carbon orthotic." I'm like, "Here's the picture, dude." So
Mm-hmm.
they made, they took care of him and did what they needed to do. But that's the only time I've ever seen that
One
happen.
of my jumpers recently, and it wasn't an orthotic, but it was the actual carbon of the spike. Had an issue where they jumped and the actual shoe literally broke and cut her foot. So
Yikes.
yeah, yeah, exactly. Yikes! But it was odd to see that carbon break. It's just the forces are just so incredible, right?
Oh, it's crazy. It's
Yeah,
crazy stuff. The nice thing though is it's super duper light and super rigid.
no
So
doubt.
you can really get a lot. And I've seen steel orthotics. I've never prescribed
Mm-hmm.
them, but I've
Mm-mm.
seen ones that have skived out as steel. The big problem I have with some of the carbon fiber and the steel ones is they can't get the heel cup deep enough. So if
Mm-hmm.
the person has any degree of increased rear foot motion. So, that calcaneus is going to evert 4 to 6 degrees as you go through the gait cycle. If it's more than that and they don't have something to bump up against and stop them, then they just slide over the edge of the orthotic and they're not getting the control.
And then they start developing some of the calluses and those type of things.
That we talked about last time. Yeah. We see that all the time.
Yeah. So terminology wise, we've already talked about some of them, but posting is probably one of the bigger ones. And you can posting, for lack of a better way to describe it, is just bringing the ground up to a certain point. And you can do it on the medial side. You can do it on the lateral side. We could talk about compensated gait and uncompensated gait. So a compensated gait is where there's a deformity. However, the person is able to adapt to their deformity and get their foot to the ground in essence. Whereas an uncompensated gait is one in which they're stuck in that varus position, for example. And in those cases, you got to be real aggressive with bringing the ground up to them. That's just two situations in which, a post and a compensated or an uncompensated gait may interplay with each other. What are some other terms that you like to talk about when you're educating your patients or other people in the field?
Well, that and just other docs that we're talking to and educating. A first ray cutout. So if you're trying to get the first ray to drop, you grind away part of the shell underneath the first med head so it drops down. You can do cutouts for any med head as far as that goes. Metatarsal pads, which generally should be placed behind the distal aspect of the MTP head in that area.
How often do you see them misplaced?
I don't have the lab put them on. So I have the lab leave the fronts unglued. I install everything myself because 99.9% of the time, they're not in the right spot. So we have 3 different sizes. We use the standard, trying to think of the name of the material. It's the blue stuff. Poron. Yeah. So standard Poron. You got to be really careful because acetone just eats Poron up. So you can't use acetone because these are all acetone soluble glues. But we install them ourselves. And I go through the patient. And when I have to do that, I always dread it. But it usually takes an extra 15 minutes or so to get that right. But it's in the perfect sweet spot for them.
Metatarsal pads were the bane of my existence when I was making them in house all the time. They're such a bear to get in the right spot, and once you put that top cover on, you're dead. Right. So
if you leave it unglued and you leave the top cover there, like ours the top covers are rounded, but they're not cut to size. Okay. And then the front half from just in front of the arch where you'd put the pad is unglued. And then if we're going to do a pad, and then we'll place the pad, we'll put that in, and then I won't even put whatever you want to call it, the protective sheet. We usually use a Cordura product on the bottom of the orthotic until after I know that pad is in the perfect place. They've been in it for a couple weeks. They know, because too many times it's like they think it's in the right spot and they come back for a recheck and it's like, oh, we need to move it just a little bit to the right or the left or whatever. But yeah, it's a whole process. And I'm sure you have a way to do it too. I've got kind of my own system that I use to do that. The biggest
I used to use lipstick. Lipstick works really good on the bottom of the foot.
Okay, I've not done that. As far as that goes, I'm usually standing them on it and then I'm making marks on the bottom of the orthotic and stuff like that. But yes, metatarsal pad, that's another one. Morton's toe extensions, things like that. People that have a Morton's toe, which sort of is like a 4-foot varus post, but not.
I think the shell is a good term too, to know what exactly that is. It's really where like the substance of the orthotic kind of comes from, for lack of a better way to describe that, right? It's really like the crux of the orthotic, the functional portion, exactly. Then there's the 4-foot extension,
top cover,
top cover, right? Heel counter or the heel depth. Trying to think of some other ones. We use a lot of scaphoid pads to beef up an arch if we needed to. I think that's a great shaped pad that really works great at really testing whether or not somebody's going to tolerate something pushing into their arch, or if you wanted to give somebody a temporary orthotic. I use scaphoid pads all the time. What's your thought on metatarsal bars versus metatarsal pads?
Don't use them.
Just pads.
Never. I don't even use pads as far as that goes. If people have metatarsalgia, their problem's not their foot. It's their ankle or their hip. They don't have enough dorsiflexion, and we don't even go there. I might put them in a 5 millimeter top cover with another 3 millimeters of Poron on top of that. or plastisode or something like that that's going to be super duper cushy for them. But you need to correct the problems way outside the foot. So we don't even go there with Met bars and stuff. Most of the time, even Met pads, I would say it's a very small percentage of folks that we use them. And we see people, and I'm sure you do, that come from the podiatrist or whoever, and they've got raging metatarsal pain, and you look at it and the shell's too long and the Met pad's in the wrong place. They don't, and you're like, oh, all right. So you move it, you grind the shell back a little bit, and they're like, wow, that's like way better. And you really didn't do, it took you 15 minutes, and you're like, all right, let's do a check in a week. And if you're good, you're good. Like, we don't need to do anything else.
Right. Exactly.
As far as that goes. So I think a lot of it is being comfortable with what you're doing, but then also educating the patient as to where they're supposed to be feeling. It's going to be a little uncomfortable at first, most of the time, but it shouldn't hurt.
Right.
Yeah. And if it is hurting them, maybe they shouldn't be in an orthotic. So
that's right. It's the wearing in. So I always tell my patients, number one, like an orthotic, number one, first and foremost, has to be comfortable, right? Can feel different and odd, but it's got to be comfortable because it doesn't do you, your coach, your other athletic trainer, whatever. It doesn't do anybody any good if it's sitting in your closet, right? So you got to wear it. And the only way you're going to wear it is if it's comfortable. Now, I always tell people, we go back and forth about this break-in period, right? So I always say, if you put it on and your pain goes away, and as long as you wear it, you don't have pain, just wear it, right? I'm not worried about break-in period. If it makes your pain go away and you like it, wear it. If you start to develop some soreness or some fatiguing of certain aspects of your foot, then obviously you want to, create a more scheduled routine of increasing the time in it, over time. And like you said, depending on the material, that's going to play a part in that as well. So a more rigid material is going to take a longer break-in period versus a soft, more accommodating type of material. So that's kind of how I do it. It's a conversation I have. It's the last thing I say after, I give somebody an orthotic and I say, okay, this is not an end all be all. We're going to work on foot strength. You've got to keep your foot muscles working, and it's got to be comfortable. So if it doesn't feel right when you put it in, different is okay. Uncomfortable is not okay. We need to have a conversation. So I'll see you back. And if it's bothering you before that, let me know. And I'm sure you do the same.
Yeah, kind of. Although I tell pretty much most people that it's going to be uncomfortable for 3 days.
Okay.
And it usually is, especially if you're going with a plastic rigid device or something like that. It's like, we do a break-in hour today, 2 hours tomorrow, 3 hours the next day. It's basically adding an hour a day, and it's an hour on your feet. It doesn't mean you're sitting at your desk, and that doesn't count. It means that you're an hour walking around. I would say with most people that works relatively well. I have people that put them in and go and run a marathon against my recommendation and are absolutely fine. They're like, oh my God, I wouldn't have been able to do it without it. So that's a good thing too. And a lot of it's the personality of the individual. You have some patients that are more and some that are less tolerant of, the aggressiveness or non-aggressiveness of the device, depending upon, what you're doing. So, I think the biggest thing is, are we changing the mechanics? Yes. Are we altering proprioception? Yes. And that's probably what's creating the change. Are we actually slowing pronation? Maybe, and maybe we're not. You look at the kinematic studies of that stuff, and it's a mixed bag. Some of them are showing, oh yes, you're making these changes, and other ones are showing, no, you're not doing squat. As far as that, but the bottom line is the person is feeling better. Their gait, at least from a superficial standpoint, when you're filming them, is looking better, and their symptoms are gone, and that's kind of why they're there. To get rid of their pain, even though we're trying to improve function and everything else. The bottom line is they're there to get rid of their pain. Yeah.
When I talk, sometimes I reference a couple of studies that showed if you're looking to decrease or improve kinetics, arch contour seems to do a better job as opposed to posting. And if you're looking at improving or changing lower extremity kinematics, then posting and wedging does a better job than the arch contour. So again, depending on the study, you may read different things, and it's not very consistent. There's so many different variables and factors that play into it, but that's just kind of the basic guideline I oftentimes go with.
I like that. I'd like to read that paper. I haven't read that one.
Yeah, so. I'll show you those. I have those. I think McLean is one of them. It's 2008, 2011. McLean is sticking in my head, but I can get you those.
Rob McLean, the same guy that did all the cervical mechanoreceptor research, or a different McLean?
Not sure. Not sure.
Yeah.
And then we talked a little bit about this as well, but the shoe orthotic interface is crucial, right? So, if we're talking, there's different ways in which you can look at this. You can look at a shoe that say has a wedge built into it, or a medial post built into it. A running shoe that has, like you said, a 4-foot rocker to it, or if you're putting it in like a cleat, let's say, which isn't necessarily always ideal. Sometimes I'll even prescribe orthotics for just my patients to wear when they're wearing their game cleats, and when they're not performing their sports, they're not wearing anything.
Right.
If I'm looking at my gymnasts, it's the exact opposite, right? They're barefoot all the time. So when they're not barefoot, I want them to rest their feet. So I'm going to have them wear their orthotic when they're walking around campus and doing those type of things. So I think it's going to really depend on the sport, the athlete, but the shoe that you're putting it in is critical to be aware of, at least what you're dealing with.
Yeah, orthotics are shank dependent devices, so they need to sit flat on the surface of what you're sticking them in. So you really need to pay attention to how it fits inside of the shoe. I like full length top covers just because it keeps the orthotic from sliding around and stuff
I
inside the
agree.
shoe. Sometimes that's not possible. You have to like Velcro it or glue it to the bottom of the shoe. Um, but a lot of times, with your heel cup, if the back of the heel cup is beveled like this as opposed to like this, if it's beveled like this, it moves the entire heel forward in the shoe. So now you're changing the flex characteristic of the shoe. And if the toe break isn't in the right spot, like we talked about last time with calluses and stuff, you're going to start screwing up their mechanics, because the shoe wants to break here and their foot wants to make the toe break here.
Mhm.
So they're kind of fighting against the shoe. Or does it fit adequately in the heel box? In other words, when you step on that orthotic, that calcaneus, unless you've got a 4-foot varus deformity that's rigid, is going to evert a certain amount. Does that orthotic stop? Can it slide around, or is it already up against the side of the shoe?
Mhm.
Also, we've got that cupping effect that's going to occur from an orthotic that's going to make the foot more buoyant, so that the calcaneus is actually more buoyant inside the fat pad. The flatter it is, the more that fat pad comes out laterally,
Mhm.
and that can potentially affect that. So the interface is important, and also not so much with athletes, but with people that are wearing high heel shoes. If they want to wear an orthotic in that for some reason, I don't know why you'd want to do that, but we've
Mhm.
certainly had people with cowboy boots and stuff like that. A lot of times you have to heat mold the orthotic so that it's got a little bit of flexion in the orthotic so that it sits appropriately inside the shoe. Otherwise, it's balanced precariously, right at the front of where the heel is. So the
Mhm.
interface is super important. And how does it change where the foot is? Like there's always bling on the outside of a shoe, like, graphics or markings or pieces of fabric or rhinestones or something, where those are. And when you put the foot in there, the foot's in a different position now. So does it potentially rub on that? Does it create an issue with where you're lacing and where that's coming across? We really try to educate our patients about that when they're doing it. We sell shoes in the office, not a ton, but some. We try to steer people towards stuff that we know works as far as that. If not,
Mhm.
we're saying, look, bring in your bag of shoes. Like, let's go through
Mhm.
and let's look at the orthotic with every shoe that you're going to wear it in. Let's take a look at how that's going to interface to make sure it's going to do right. And for some shoes, we'll make a tiny modification inside the shoe, and so that the orthotic can sit flat or move medially or laterally. Sometimes if it's everting too much, you have to put a little pad there on the outside of the orthotic, or you're changing the rounding. There's a lot of that subtlety with what
Mhm.
you're working with, but I
Mhm.
think that that's super important.
Mhm.
um, yeah, I can't emphasize that enough.
Yeah, so a couple things. So one of the throat of the shoe, and arch fill sometimes doesn't always work well in my office. So I oftentimes see like having to go in with a grinder and really kind of decrease some of that added arch fill if I've ever ordered, to add. So arch fill adds extra stability to the insert. It just builds up the medial portion so it's a little bit more beefy. But oftentimes if the shoe throat is pretty narrow, it doesn't sit very well, and you get a cantered type of orthotic, which again shifts them more to the lateral side of the foot, which isn't necessarily ideal either. And it just really it excessively inverts the foot, which is somewhat a disaster too. And then I always got to think about, with my athletes, it's not always, normal heel toe gait mechanics that I'm dealing with. It's sports, it's lateral movements, it's shifting, it's pivoting, it's a lot of friction in tennis and sliding. And so I tend to be, I know you mentioned before, you tend to be more aggressive and then kind of count backwards and then kind of decrease. I tend to go a little bit more the opposite way. I tend to be a little bit more conservative, and how much can I get away with not doing and still creating a relief that person was dealing with. So different ways to handle it. I don't want to overcompensate and run the risk of, say, medially posting somebody into an inverted position and putting them at risk for an ankle sprain if they land funny. So that's just some of the things that are, running through my head when I'm doing some of the orthotics. I tend to be less aggressive with posting and wedging unless I really need it, just because of, again, my athletes tend to be a lot more, at least the ones I tend to see are a lot more court sport and field sport driven, where it's not normal mechanics that you're always kind of shooting for. The other thing that's interesting is, have you ever come across, Ivo, it's a basketball shoe. It was several years ago. It was the Kobe. And we didn't mention that when you put an orthotic in, you typically have to take the sock liner out, or that footbed that came with the shoe out, and replace it with the insert, right? Well, the Kobe had, no joke, an insert that came in the shoe that was this thick, right?
Oh my gosh.
It was ridiculous. And actually the orthotic lab that I work with works very much with the NBA. And we actually had to reach out to the NBA and say, guys, this is not good. Because if we are going with a custom insert, we put that orthotic in. Most custom orthotics don't take up the space as that same, thick durometer. It was like, what's the word I'm looking for? Stack height. It almost like increased the stack height by, I don't know, 4 or 5 inches. It was the most absurd thing I've ever seen. And you'd stick an orthotic in, that person would lose like 3 inches of height just by sticking them in the orthotic, as opposed to having the insert that came with the shoe. So that messes with how the foot interplays with the upper of the shoe, and how the arch fits and where the break is. So all of that kind of play. So we actually had to really discontinue using that shoe, just because it didn't work with what we were trying to do. I was just wondering if you ever came across that shoe also. It was miserable.
Yeah. No, I have not, but I've seen other shoes that have super thick insoles. We have EVA in the office that we can take up, like 35 durometer top cover material, that we can take up extra space and volume. We do that with ski boots quite a bit.
There you go.
As far as that goes. But yeah, just 2 quick comments on what you
Sure.
said. One, you were talking about gait. So if the person is a 4-foot striker and they're on their forefoot the whole time, the orthotic's really not going to do much.
Correct.
You're not going to be changing unless you have 4-foot posting on that.
Correct.
Orthotic. It's just not going to, it's just, and the other thing is, an orthotic is going to beef up the shoe that you put it in. So if you put an orthotic in a motion control shoe, it's going to be way more motion control. Correct. You can take a shoe that's softer, a neutral shoe, and make it into a motion control shoe with an orthotic, but it doesn't really go the other way. So that's something to think about as well. If you got somebody in a brick like a Brooks Beast or something like that, which is a great shoe for the right foot. I don't know if there's too many cases where you're going to stick an orthotic on top of that shoe. Correct. to make that like work better for them. But remember, it's going to amplify the effects as well as the defects, which are in the shoe. We talked a little bit when we were talking about calluses about how the upper of the shoe sometimes is canted medial or laterally on the outsole when it's put together at the factory, wherever it's put together. And if it's in varus and your orthotic's in varus, now you've got double the varus. Or sometimes if it's in valgus and you're putting it in varus, now you're neutral again. So you really aren't accomplishing it. So you really need to pay attention to manufacturer defects and stuff. And we'll put out a couple things on the blog and on the podcast here, just looking at that. I've got a bunch of videos with cleats and things like that we've done in the past, where cleats are the worst. We grind cleats all day long for the soccer teams and the baseball teams, just to create a level surface for the folks. But yeah, that shoe orthotic interface, that's super duper.
It's huge. Yeah,
it's huge. And then the other thing, I think the next slide says this, but the big thing in our office, and I'm pretty sure you do the same thing, it's orthotic therapy. It's not set and forget. You don't put it in and like, all right, see you later, and you never see them again. We do a recheck at usually 2 weeks, 4 weeks, and 3 months, unless they're absolutely perfect, and they have to call the office and check in like, hey, I love them. If the doctor changes them, I'm going to really, really upset. Then we don't do a follow-up. And our idea is they're exercising all while they're wearing this device. They're doing their therapy. If they're working with our office, great. If they're working with one of the other offices in the area, or we've got people from all over the country, their therapist. As they get better, we should be able to pull correction out of the orthotic.
Mm-hmm.
And that's why we call it therapy. So their script should be changing, and it should be less and less as they're going through. Our goal is to get people so they really don't have to wear an orthotic. Ideally, we try to get people as good as they possibly can be without an orthotic first, and then give them an orthotic to give them that last little bit of range of motion or whatever mechanics that they don't have. It doesn't always work that way. Sometimes it's the other way around, but we're always trying to pull the correction out and make them better. Kind of like eyeglasses. We wear them, and every time you go, your prescription gets worse, right? Because one, you're getting old, and two, it's just like, we don't do eye exercises unless you like use the Bates method or something like that, which they really do work as far as the accommodative exercises and stuff. But we're always trying to get people out, and they're always amazed. They're like, wow, all I ever did was I would just get my script updated every couple of years. It's like I'm not even going to have to, I don't even have to wear orthotics now. And it's like, right. That's the whole idea. It's like,
Correct.
you don't need something else you have to remember when you go to the gym, like to take out of your shoe or whatever. Cause or people leave them on their dashboard and go to Moab and they melt, or whatever, cause it's 150 degrees in their car, or something like that. But yeah, I think the therapy and the treatment is just as important. Now, some people, you got people with, equinal varus deformities and club feet and stuff like that, or rigid, first raise or, fixed hallux limitus. They're going to need an orthotic. I mean,
Sure.
You're not going to be able to get them probably out of that. But there's a good number of folks where they have, relatively minor problems that we can ultimately get them so they don't have to, or they can wear much less of a device, or sometimes we can move them from a custom just to an off the shelf. And that's always nice because off the shelf is like $50 as opposed to $450 for a custom device. So
yeah, I'm good. We could talk off air about what we charge and what you charge for orthotic.
Yeah.
But what I'll say is this also. So I'd much rather, when I'm dealing with a lot of my runners and such in that population, I'd much rather go with a shoe that is more, we can start talking about heel drop, but I like because most motion control shoes tend to have a higher heel drop. They tend to be, more heel dominant, more heel heavy. I'd much rather go with a neutral heel drop or a 0 to 4 millimeter heel drop shoe with orthotic to add stability, as opposed to going with a 12, 13, 14 millimeter heel drop shoe that has a stability built in. I just feel personally that, and this is my own thought process, that heel drops of that magnitude oftentimes dictate how a person hits the ground. And I'd much rather have an interface or a shoe that mimics our foot characteristics more naturally, as opposed to a beefy heel cup. And so that's how I would say I'd much rather go with an orthotic that I can wean down and we can put the support in the areas it needs to be, and it's still lightweight, as opposed to that. I was wondering your thoughts.
I agree completely. As far as that goes, would much rather do more with less.
Correct.
Yeah.
All right. So I think we bring it to summary. So summary, I just say that, orthotics are something that's important. I think it's a great tool for my toolbox. It's a way for me to allow my athletes to perform activities, hopefully in a more aligned, less damaging or a less irritating type of position that they're currently dealing with. Like Ivo said, it's not set it and forget it type of modality or treatment. It is something that, other things should not be neglected, like foot strength. And, like we talked about a little bit before also, if somebody's lacking mobility in a certain area, you need to address those things as well. Otherwise, you're just asking for other problems down the pipe. But they're a valuable tool for me. It's one of the most valuable tools I've got in my practice as a lower extremity specialist, somebody that deals with foot ankle issues all the time and running and lower extremity pathology all the time. And I know Ivo feels the same.
Yeah, absolutely.
So, yeah. Anything else to add before we cut it?
No, just we do have a seminar coming up, and if the seminar's already passed, you can go to the website and look for some of the post-seminar offerings. But it's all about orthotic therapy, grinding, posting, casting, all of that stuff. And it'll be covered in a 2-day, 20-hour marathon session with tons and tons of hands-on. It'll be done out at our office, so you'll be able to grind, post, do all of that stuff yourself and have all those skills to take back. If you're interested, check out the website. There's a link there. You can follow that link. It's coming up in October.
I agree. Thank you again for joining us. We have a lot of stuff on our YouTube site as well, more, shorter type videos. And if you have questions, please leave them in the comments. We're happy to answer those as often as we can. And hope to see you back soon. Thanks so much.
Take care.